I'm Dan Resnichek from Pacific Northwest Urology, and today we're going to be discussing the basics of prostate cancer. The focus of this video today is to go over the basics and educate men and their loved ones on the initial diagnosis and workup for prostate cancer. We're going to discuss what prostate cancer is, how it's diagnosed, how do we stage prostate cancer, what are the statistics about survival, and over the next few videos I'll be going over the risk stratification for prostate cancer and some treatment options for prostate cancer. Prostate cancer is constantly changing, and it's important to note the guidelines and recommendations for prostate cancer change over time. This video is based on recommendations from the National Comprehensive Cancer Network Guidelines, or NCCN. They also have great patient guidelines that can be referenced at nccn.org if you are looking for more information on the topic. To start my discussion today, let's first answer, what is prostate cancer and how is it diagnosed? Prostate cancer is a cancer coming from the prostate gland. Cancer in general describes a group of cells that have developed a mutation and grow out of control. The prostate is this half football-shaped gland that surrounds your urethra just below your bladder. Its general function is to make a small portion of the fluid in a man's ejaculate when they orgasm, and it's also the location where the seminal vesicles and the vas deferens combine and join the urethra. In the United States, about 99% of prostate cancers are what we call adenocarcinomas, or these are cancers that are arising from the glands of the prostate itself. There are other rare prostate cancers that I'm not going to talk about in this video, but those cancers include things such as small cell carcinoma of the prostate, or sarcoma, neuroendocrine tumors, and rarely urothelial cell carcinoma. How dangerous is prostate cancer? In the US, prostate cancer is the most commonly diagnosed cancer among men, with almost 300,000 men being diagnosed with prostate cancer every single year. Most prostate cancer is diagnosed at an early stage, and most cancers are low risk. Overall survival for prostate cancer is very good, with 1 in 8 men being diagnosed with prostate cancer sometime in their lifetime, but only 1 in 44 men dying of prostate cancer. When people are diagnosed with prostate cancer, I commonly hear the phrase, well, if we live long enough, we will develop prostate cancer at some point, or it's a slow-growing cancer that you're going to die with rather than die of. This phrase has some truth to it, but it can also be quite misleading. Although that is true for many of the patients with low risk or even intermediate risk prostate cancer, and most of them do well within 5 years, and survival rates for early prostate cancer approach 100%, men with high-risk disease or metastatic disease can be deadly. Remember, 35,000 men in the United States die of prostate cancer every year. And of those diagnosed with metastatic prostate cancer, the 5-year survival rate has improved over time, but in the last 20 years, it still stands at around 37%. So for prostate cancer as a whole, the balance that we have to do is weigh the risks of the cancer with the risks of the treatment options. For some men, the disease is very slow growing and non-aggressive. For others, it can be deadly. So it's important for us to find the men who have high-risk prostate cancer before it spreads to other places of the body where it's still curable. If we do a better job of finding these men, we can improve survival for prostate cancer. So, how is prostate cancer diagnosed? For the vast majority of men with prostate cancer, there are no symptoms at the time of diagnosis. That is because for the last 20 to 30 years, there have been tests that help us screen to find men that have prostate cancer. Screening for prostate cancer is testing asymptomatic men with increased risk. The most common test used to screen for prostate cancer is the PSA, or prostate-specific antigen test. The PSA blood test can be elevated in men with prostate cancer. The merits of the PSA test and the debate about screening are a long topic for another video, but for the purposes of this video, most men who are diagnosed with prostate cancer have been diagnosed because of a PSA test. Now, some men may be diagnosed with prostate cancer due to symptoms. Early symptoms of prostate cancer may be very similar to the symptoms of normal non-cancerous tissue within the prostate. This growth is commonly referred to as BPH, or benign prostatic hyperplasia. The symptoms of BPH may include symptoms of a slow urinary stream, frequent urination, increased urgency, or increased nighttime urinations. For the majority of men who have these symptoms, it is due to benign growth or normal BPH. But in a small percentage of men, it may be due to prostate cancer. If you are experiencing these symptoms, you should be tested and checked for prostate cancer to make sure that that's not the cause of these symptoms. Some of the symptoms of prostate cancer develop much later, at a time where the cancer is no longer generally curable. These type of late symptoms happen when the cancer is spread beyond the prostate itself. These symptoms may include back pain, weight loss, or blockage of the ureter known as hydronephrosis. So when a doctor is worried that you may have prostate cancer, they may order additional diagnostic tests to help with the diagnosis. One of the first tests performed is usually a digital rectal exam. Although studies have shown that by itself a rectal exam is not accurate to determine or screen for prostate cancer, it is important for men with an increased suspicion of prostate cancer or an elevated PSA. In fact, the digital rectal exam is still part of the staging for prostate cancer itself. Additionally, multiple studies that show that for men that have prostate cancer, those that have an abnormal physical exam often have worse findings, and that is why it's still used to stage prostate cancer. Other tests that may be used to help or aid in the diagnosis of prostate cancer include imaging tests, such as a multiparametric MRI or molecular markers. Some of these molecular markers can be found in urine tests or blood tests and are more accurate than a PSA itself. There are multiple molecular tests on the market today. Of the tests that are out there, they have a higher accuracy than a PSA itself, but they're also more expensive and they are not always performed. These molecular tests may be helpful in equivocal cases or when trying to make a decision about whether or not to do a biopsy. These tests include tests such as a select MDX test, 4K score, EPI test, and more. It's important to note that although you may have an elevated PSA or elevated molecular score test or an abnormal MRI, these may be all suggestive of prostate cancer, but the only way to get a diagnosis of prostate cancer is to obtain a biopsy or a tissue sample. A tissue sample allows a pathologist to look at the cells under the microscope in order to make a diagnosis of prostate cancer or determine if prostate cancer is not present. There are multiple ways to perform a prostate biopsy. Most commonly, this is done with needle samples taken from the prostate using an ultrasound for guidance. In some patients, samples of the prostate may be taken during another surgical procedure, such as a transurethral resection of the prostate. Once prostate cancer has been diagnosed, it's important to figure out the aggressiveness of the cancer and to figure out the extent that the cancer has spread. These two factors are the primary determinants of the risk of the cancer itself. As we talked about earlier, determining the risk of the prostate cancer helps us determine our next steps and what our treatment options are. In medicine, when we talk about cancer aggressiveness, we usually refer to the grade of the cancer and the stage of the cancer. The grade of the cancer refers to how aggressive the cancer cells look under the microscope. This is determined by a pathologist. Stage of the prostate cancer refers to how far the cancer itself has spread. This is typically determined by the digital rectal exam and also imaging tests. Historically, the grading of prostate cancer has been confusing for patients to understand. Pathologists assign various patterns in terms of aggressiveness of the cells on the microscope. These were referred to as the Gleason score. Originally, there were scores 1 through 5. After 2005, grades 1 and 2 were removed, so the Gleason score started with a lowest score of 3 and the highest score of 5. A pathologist looked at the cancer cells and then determined the Gleason score by a combination of the most common pattern seen plus the next most common pattern seen. So scores were then shown as 3 plus 3 equals 6, 4 plus 3 equals 7, or 5 plus 3 equals 8. Any combination of the most common aggressiveness that was seen and then the next most common. This was a fairly confusing scoring system, given that the lowest combination possible was a 6 and the highest was a 10. In 2014, the International Society of Urological Pathologists came together and proposed a new grading system. This new grade grouping system was easier for patients to understand, with grade group 1 being the least aggressive and grade group 5 being the most aggressive. This new grade group system was adopted by the World Health Organization in 2016, but patients may still see the old system in use. As I stated before, staging the prostate cancer is the next factor in determining the risk of your cancer. This involves figuring out how far the cancer has spread within the body. We typically use the TNM system for prostate or for any cancer. The T stage refers to the tumor stage, or how far advanced has the local or original cancer grown. The N in TNM refers to the node stage, or lymph nodes. And for prostate cancer, it refers to whether or not lymph nodes are involved. M refers to metastasis, or if the tumor has spread beyond the prostate and the primary lymph nodes. If the cancer is anywhere else in the body, it is referred to as metastasis or metastatic. To stage your prostate cancer, a urologist may do additional tests beyond just the biopsy itself. Now, not all prostate cancer is staged by imaging. Some of the less aggressive cancers are not recommended to get any additional imaging. So the recommendations for staging depend on how aggressive the cancer is on the biopsy itself. As we'll find out later, for low and favorable intermediate risk disease, for example, the risk of lymph node metastasis, the risk of lymph node involvement or bone involvement is incredibly low, and it is not recommended to get bone or soft tissue imaging in these patients. Additionally, other patients who have non-aggressive disease and less than 5 years of life expectancy, no additional imaging is recommended. In terms of what imaging may be performed to stage your cancer, there are a variety of different imaging options available, and there are some benefits and drawbacks of each of these tests. The most common imaging test used for staging is probably the prostate MRI. Other tests may include CT scan of the abdomen and pelvis, a whole body scan, and recently there have been various PET CT scans that help us stage prostate cancer. The most common new PET scan is called a PSMA PET scan. Your provider may recommend one of these tests over the other based on a variety of factors. Generally speaking, an MRI of the prostate gives us a good view of the soft tissues and a zoomed-in view of the prostate itself. And this is good for finding soft tissue lesions such as prostate cancer. It is a good picture to see the T stage of the prostate cancer and see if the cancer comes up to the edge of the prostate. It's important to note that prostate MRI does not pick up all prostate cancers, but is generally good at visualizing the more aggressive prostate cancers. If the cancer is visible on the MRI, it may show us where the cancer is located within the prostate gland, or if it's growing to the edge of the prostate gland, or what we call the capsule of the prostate. In some patients, it may also show if it's growing outside of the prostate. In addition to looking at the prostate itself, the MRI looks at the seminal vesicles, the bladder, and some of the pelvic lymph nodes and bones immediately around the prostate itself. It does not give us a zoomed out view of the rest of the body, but really focuses on the pelvis itself. A CT scan is another option for some prostate cancer staging. This uses X-rays to scan and look for prostate cancer outside of the prostate gland. It is not as good as an MRI at picking up cancer inside the prostate itself. However, CT scans can see larger abnormalities outside the prostate, such as potentially lymph node involvement, and it is very good at looking at the bones and finding if there is any bone involvement of the prostate cancer. Speaking of bones, a urologist may order a bone scan as a test to examine if your prostate cancer has spread to the bones of the body. A bone scan uses a radioactive dye that's put into your veins and circulates through your blood system. The dye in a bone scan preferentially goes to areas of new bone growth. Bone scans can help highlight if the cancer has spread to the bone itself. Bone imaging for prostate cancer is not recommended generally unless the cancer is more aggressive, such as unfavorable intermediate risk prostate cancer or higher. The reason for this is the risk of bone involvement is not common at all with low or favorable intermediate risk prostate cancer. Recently, there has been an increased use of PSMA PET scans for prostate cancer. This scan combines a CT scan plus a radioactive tracer scan. These two images are then combined to show a fused image. PSMA PET scans are currently the most sensitive test at picking up prostate cancer. That means this test can detect it at very low amounts compared to other tests. Another way to say this is that the PSMA PET scan can pick up prostate cancer that is spread at a lower PSA level than other tests. The molecule used for this test preferentially sticks to PSMA, or a marker that's present on most prostate cancers. Although this test is very accurate, it's also quite expensive. Since low or favorable intermediate risk prostate cancer are very unlikely to have cancer outside the prostate, again, this test is only recommended for more aggressive prostate cancers. Once imaging has been done, or you have a grade and stage for your prostate cancer, as well as a PSA, you can be assigned a risk group. Risk groups for prostate cancer start with very low risk prostate cancer and go up to metastatic prostate cancer. The risk is a combination of the stage, grade, and PSA, and these can be found at nccn.org. In addition, I'll have another video coming out soon to go over the different risk factors and different risk groups. In addition to the tests that we talked about already, your physician may order additional molecular testing of the cancer cells taken from the biopsy itself. Some of these new molecular tests may help determine risk in a different way from the other tests that we have as well. These molecular tests are not always performed, as they do not always affect the treatment plan. For example, for a young healthy patient with high-risk cancer that is localized to the prostate itself, the recommendation is going to be for treatment, whether or not the molecular test has a different finding. There are a number of different molecular tests on the market today. These include tests such as the Decipher score, Polaris test, GPS, known as Genomic Prostate Score, and Artera AI Prostate. In general, these tests look at different genomic assays from the prostate cancer itself. They are looking at the RNA of the prostate cancer is making and help determine your risk. Your physician may use these tools to determine recommended treatment. Sometimes your physician may also use these tests to help determine the intensity of the treatment that they're going to recommend. Overall, these genomic tests provide some additional information about the cancer risk and may be beneficial for some patients. It's important to talk to your urologist about if these tests may be helpful for you. When looking at cancer guidelines, these molecular tests are not a replacement for the other tests that we have currently been using, such as the stage or the grade of the cancer. And thus far, these tests do not significantly change the treatment recommendations based on prognosis or based on risk stratification. We currently do not have enough data to state that these molecular tests are better than what we use already. All right, to summarize what we have today, prostate cancer is a very common cancer in men. It is the most common non-skin cancer. The aggressiveness of prostate cancer can vary significantly. For most men who have prostate cancer, they are diagnosed with a non-aggressive cancer. However, some men will be diagnosed with high-risk or metastatic cancer. Aggressive prostate cancer does have a potential to metastasize and to kill men. So, to determine your individual risk and what treatment options may be best for you, you will need a PSA, the biopsy grade, and potentially imaging tests to determine the stage of your cancer. In some cases, your urologist may order additional tests such as a molecular assay of the cancer to help determine your cancer risk. All right, so for my next video, I'm going to go through the various risk groups for localized prostate cancer, and that's going to go over how we determine that risk and also the treatment options that are available for each group. In the next video, we're also going to go over the added complexity about deciding whether or not to treat the prostate cancer, depending on other medical conditions and patients' life expectancy. The options that we're going to cover in that video are going to be the options that are currently listed in the NCCN recommendations as of 2024. Those options include active surveillance, surgery, and radiation therapy. All right, so that was a very brief highlight of prostate cancer overall. If you like that video, please click like or subscribe below. And in the next few videos, we're going to go over, like I said before, the risk groups and treatment options in more detail. Thanks for watching, and we'll see you soon.